afternoon.
Thanks, Rob. And thank you for the organization for the invitation. These are my disclosures. So, you know, we do a lot of embolization, and I would say there are three things that truly impacted our practice. One is working in a multidisciplinary setting. Number two is actually radioembolization, we'll briefly discuss. And number three is the utilization of ConeBeam CT. So are we as good as we think we are, and could ConeBeam CT improve our targeting, and could that translate into improved patient outcomes? Well, start off with some literature first. Miyayama out of Japan initially used this idea of ConeBeam CT and did it change technical success in the cases that they did, and roughly 100 patients in each arm, DSA versus ConeBeam CT. And they used a different grading scale, and what effectively came out of this study was that those that had utilization of ConeBeam CT, it significantly impacted how they targeted lesions and made them go back and technically catheterize different vessels. And so there was a significant difference in technical success between DSA versus ConeBeam CT alone. And this intraprocedural ConeBeam CT, as evidenced in this case study, showed that there was incomplete targeting sometimes, and so that led to decreased objective response. Iwasawa took it a bit further and looked at, does this retrospectively, in a retrospective analysis, does this impact survival in patients? And they took chemoembolization patients who went under DSA alone versus DSA plus ConeBeam, roughly 60 to 70 in each arm. And they saw that patients receiving chemoembolization with ConeBeam CT had a significant higher local progression-free as well as overall survival compared to DSA alone. And the multivariate analysis also held true on this study as well. John Louis out of Stanford looked at this in regards to radioembolization, and basically what they did was compared the same group, DSA versus DSA plus ConeBeam CT. And what they found was that ConeBeam CT changed management in how they were going to do the procedure, because radioembolic beads cause significant more non-target damage than chemoembolization. And so the ConeBeam CT provided additional information that was not detectable on DSA or mapping with macroaggregated albumin. So just to lead off with some case studies from our own experience with ConeBeam CT, you can see that this patient had about a 4.5 centimeter lesion in segment 4 of the liver. We wanted to downstage this patient so that they could undergo liver transplantation. Otherwise, it was a healthy individual, child Zay, with an ECOG performance of 0. And you can see on this digital subtraction angiography, it's very easy. You can see that there is a large hypervascular lesion that's arising from segment 4 of the liver. And so we catheterized segment 4 and did a subselective angiography. But what you can see is you don't see the whole lesion light up on this subselective catheterization. It's only almost half of the lesion. And so we did a ConeBeam CT, and we saw that only half of the lesion truly was lighting up on the CT reconstructed images. And so we catheterized the second feeder and fused the two images together, and now we had a complete image, almost like a puzzle. And the patient, more importantly, underwent catheterization of two separate arteries, which appeared to be one on the DSA, and on 3-month post-follow-up had a complete response according to modified RESIST. And on the 20-minute EOVIS delay, which looks at the hepatobiliary phase, this was true, and you can see the zone of demarcation from the radioembolization. The second case is how we use it when we use conventional chemoembolization with Lepidol and doxorubicin with an oily mixture. And so you can see that this patient had a previous local regional therapy, but there was recurrence along the margin. And so this recurrence along the margin we wanted to treat with a transarterial-based therapy because we thought ablation was not a good target in this situation. What we did, again, this was coming off of segment 4, and you can see on that angiography, it's very difficult to see because of the hypervascularity of that vessel. And certainly you don't see that lesion quite well on the DSA. With the same injection rate in that same exact vessel, we did a ConeBeam CT, and these are the coronal reconstructions in arterial and venous delay. And you can see that that lesion actually lights up like a light bulb. And so this information is invaluable for our therapies because this was not seen on that digital subtraction angiography alone. So what we have on our software, it's a Philips software. We have what's called Embo Guide or embolization guidance. And what we do is we segment out our target or our tumor in arterial phase, and then the software automatically selects out which vessel is leading to this target. And so you have a 3D roadmap that you can use to greatly reduce fluoroscopy time as well as radiation and lead you to your vessel. So we performed our conventional ConeBeam CT here. We sub-selected out for the lesion, which correlated quite nicely with that pre-procedure MRI. And again, more importantly, on that 1 month follow-up, you can see a complete response, necrotic tissue according to modified RESIST. How about this new technology that has come out in the past year called Radiopaque Beads? The beads that we used prior to this technology, you could not see either under fluoroscopy or conventional CT. With these radiopaque beads, they're injected with barium, and so you can see these either under fluoroscopy or with ConeBeam CT. So this is a individual with HCC, a large 4-centimeter lesion in the right lobe of the liver, otherwise good liver function and good performance status. The MRI arterial and venous delay shows approximately a 4-centimeter lesion on the periphery of the right lobe of the liver with arterial enhancement and washout on delay, classic according to ASLD guidelines for HCC in the setting of cirrhosis. We performed a celiac angiography, and you can see that there is a hypervascular lesion on angiography. We again did ConeBeam CT in arterial phase, which correlated with the pre-procedure MRI, and we use EmboGuide. And so this is a 3D roadmap reconstruction for us to go out to subselectively, and you can see that there are approximately 5 feeding vessels to this tumor. And we try and subselect as much as possible, and you can see that there's an image overlay with our fluoroscopy. We performed our radiopaque beads and allowed 10 minutes for washout so that we can see exactly the distribution of the beads, and this is what's left behind. There's a little bit of non-target embolization, but we've targeted the liver quite nicely. And what we do is we fuse the arterial phase, which is the image on the left that we initially performed, with our post-treatment, which is the left with the radiopaque beads. And once we fuse those images, you can see that we have good overlay, with overlay being red and white. And so we had very good targeting of this. We got a 6-week follow-up, and you can see there's a complete response according to modified RESIST. We also use this to help us with decreasing radiation dose. And so PET-CT and ConeBeam CT in the 68-year-old male with metastatic esophageal carcinoma lesion next to the IVC, a difficult target for ablation. And so on the mapping procedure, you can see that there is a hypervascular lesion arising from segment 7. Again, we use ConeBeam CT reconstruction and vessel identification, or EmboGuide, to navigate through this very, very tortuous anatomy. And we had a 3D roadmap for us to navigate through. If you look at we wanted to lay the vessels out because there's a lot of tortuosity here. And basically, on the computer, you can lay out the optimal angle for your procedure. And before we even touched the fluoroscopy pedal, we rotated to +35 and kept the angle at 0. And so this is what we started off with, 35 and 0, without even doing anything. We got to our destination with the best angle to lay out the vessel, and you can see that we targeted it quite nicely. This is the ConeBeam CT reconstruction, no non-target, just to the metastatic tumor process. And this is the pre-procedure PET-CT. And this is the post-Y90 imaging after we injected our therapy. And then again, 4 weeks later, you can see on PET-CT follow-up that there is no enhancement of that lesion with a complete response. We can also use the ConeBeam CT, which is on the image below, correlating to the MRI. And we've published on this as well, that you can get tumor volumes as well as perfusion volumes for your dosimetry for your Y90. And lastly, you can use your ConeBeam CT for percutaneous targeting of lesions. And so you have your skin entry as well as your target endpoint, and you just rotate your II to be on your target site, which is overlapping of the target circles. And so we did a biopsy of one of the lesions that we were treating because we needed it for therapy. And again, a ConeBeam CT to verify that we were truly inside the target. So in conclusion, ConeBeam CT in interventional oncology, it can improve targeting. It's been shown to improve overall survival and progression-free survival. It could potentially change your management. It can be used for perfused and tumor volumes in dosimetry for radioembolization. And the guidance software can improve your accuracy of tumor feeders and potentially decrease procedure time as well as radiation. And you can use the fusion for confirmation of targeting. Thank you.